Hello, sophomores. I want to talk to you this hour about trauma, which is just burgeoning with research and development here. And especially over just like the last few years, we have become way more adept at treating a patient with trauma. And we also need to experience it within ourselves. We might have something called secondary trauma. So we're going to go over this. Our objectives are going to be exploring the nurse's roles immediately following the trauma and also following a victim's recovery there. We're also going to explore the nurse's susceptibility to secondary trauma. So there's quite a few things that we are finding out about trauma, some that we know and some that we are discovering. We do know that it overwhelms normal compensatory methods, and we can certainly not predict how we or a person will act in response to a trauma. There is really no right way to respond to a trauma, and it kind of can frustrate the nurse that doesn't have this education, because we expect our traumatic patients to be full of hysteria, and this is just kind of simply not the case. I've done lots and lots of research on post rape victims, and they will usually only have kind of this hysteria, or how you would kind of think the normal response might be, like 11% of the time. It's very small that a person will actually come in with that kind of hysteria there. We do know that during a traumatic event, we will start up the sympathetic nervous system response there, and we will do a fight, flight, or freeze, and there's a little video that's going to help you kind of figure those things out. We do know that movement, speech, sensory input, memory, cognitive processing through our hippocampus, decision making through our prefrontal cortex, all of that are impaired during a traumatic event. So a person might not be able to tell you right away or tell you at all, kind of the details of the trauma. A lot of those areas are shut down. So I wanted to share a video with you, and if you feel like you might be triggered yourself, please don't watch this video. Go over the next, skip over the next couple, 2 or 3 minutes, because it can kind of elicit a response here. But basically, this is a woman who was held captive in a shipping container for a long amount of time. And when she is rescued by her rescuers, the paramedics and police officers, she doesn't respond in a way that you might have anticipated. In fact, when you watch this video, you'll probably notice that the paramedics seem to be more anxious than she is. And once again, we cannot tell a person how to act during a traumatic event there.
Watch out, y'all move. I got it, watch out.
Coming through, okay? What's your name? What's your name, man?
Lauren, gotcha. All right.
Just a girl.
Just a girl.
How are you, honey?
This is
bolt cutters.
This is our investigator. These are paramedics.
Oh, yeah.
Okay, we're gonna get you out of there, okay?
Just hang loose for me. Anybody got I need a handcuff key.
Handcuff key.
I got it right here. Hold up. Don't slide back.
He's got a light. We gotta get pictures. Randy, let me see your light, Randy. You can put your hand down. I got no, mine's on my car. Mine's on my car.
Bolt cutter. Just hit the chain right there, loose. Just right there at her hand, Brandon. We'll get it off.
Get it off here. Cut it right here.
Do you know where your buddy is?
Charlie? He shot him.
He shot him?
Who did?
Todd Colhep shot Charlie Carver 3 times in the chest, wrapped him in a blue tarp, put him in the bucket of the tractor, locked me down here, and I've never seen him again. He says he's dead and buried. He says there's several bodies dead and buried out here, and he says that the dogs will be ruined if they go looking because there's red pepper.
We're gonna step you up, sweet. Because there's what?
Red pepper.
Tell the dog people that.
He says
No.
there's pepper everywhere around the car, the car supposedly moving after the land. Supposedly covered in paint.
So as you can see here, the responses of this poor woman who has undergone a massive trauma are quite matter of fact. So once again, we cannot tell a patient how to respond during a trauma there. Just as we were going through, the patient may have a varied affect. They may even be flirty with our staff, and these are compensatory mechanisms, our defense mechanisms there. And they may giggle a lot. I tend to giggle a lot when I'm in an uncomfortable situation. I don't know if you guys noticed that. It's one thing that your teacher does. And they may have a complete dissociation and avoidance of the topic. So you might get an individual that's just completely, in your eyes, uncooperative. And there's this great little video that could not do, that I could not do justice to. So I wanted to add this video in and show you guys about trauma in the brain. Kind of sums it up here.
We need to take a statement so we can establish what happened on Saturday night.
What time did you get back to David's flat?
What time? I don't know.
Can you give us an estimate?
I don't remember.
Would your pals remember what time you left the club?
He seemed nice.
She didn't remember much, did she?
I know. And now we've got to waste more time on a daft lecture. We know how to deal with victims. We've had years of experience.
Well, some of us have had more years than others.
I'm in my prime, I'll have you know.
That'll be right.
Today's session is about trauma. The latest in brain science will help you in your work. I'll start with a tour of the parts of the human brain. The reptilian brain maintains basic bodily functions. The limbic system is also instinctive. It deals with fear and pleasure. For example, you pat a dog, it senses pleasure, and without thinking, wags its tail. The neocortex is the site of logic, imagination, planning, and control. It's more sophisticated, but because it's conscious, it's slower than the older parts of the brain. The amygdala is a key part of the limbic system. It has one job: to sense danger and set off the alarm. When it's a matter of survival, the primitive parts of the brain override the conscious part. There are 3 possible survival responses: fight, flight, or the one that people don't think of, freeze. When the alarm goes off, blood and oxygen are diverted to muscles, adrenaline floods the body, and all systems that are not crucial to survival are switched off. Normally, the job of the hippocampus is to file memories so you can retrieve them later. But in times of danger, it stops filing memories, which makes it harder to gather evidence later on. Instead, the hippocampus switches to pumping cortisol. What's useful about cortisol is it stops us feeling pain, so we can focus on survival. Can anyone give me an example?
A farming accident where a man carried his own arm for a mile without feeling any pain?
Yes, excellent example. It is an evolutionary safety mechanism which is fast and instinctive. In essence, it's our body's very clever way of protecting us. To recap, an example of the three parts of the brain working together. You're standing at a bar. Your reptilian brain is keeping your heart beating. You're enjoying the pleasure of a nice pint with your limbic system. You're using your neocortex to work out if there's time for another before the last train. What could happen to make the amygdala kick in? What if this happened? The way you'd respond would depend not on your logical brain, but on your instinctive brain. Being glassed in a bar would be a traumatic experience. Who can give me another example of an event that can cause trauma?
War?
Rape?
A car crash?
Good, yes. Trauma occurs when a person is overwhelmed by something beyond their control. The survival brain takes over the rational brain. It can lead to post-traumatic stress disorder, PTSD, with symptoms that last at least a month. Vicarious or secondary trauma is something you may experience if you deal with incidents such as rape or sudden death, or think of Lockerbie, Dunblane. You're not superheroes. Having a brain makes you all vulnerable to secondary trauma. It's important to understand that when trauma occurs again and again, it can become complex PTSD, such as in domestic abuse or child sexual abuse. The alarm system in the brain becomes jammed. Memories are stuck in the limbic system, so a trigger can set off the alarm. The trigger could be anything: a colour, a smell, a sound, a sensation. Now, the indicators of trauma. What should you be looking out for?
Depression. Crying a lot?
Yes, that's one response. And at the other end of the spectrum, total numbness.
Nightmares? Flashbacks?
Stress.
Good, yes. And they may feel sick. Also, shame, feelings of guilt, inability to enjoy sex, social isolation, triggers. People often feel overwhelmed by the symptoms of trauma. This can lead to using alcohol or other drugs to block out memories, or self-harm, or dissociation when a person's mind detaches from reality. Indicators can be specific to the type of trauma. Say, dental problems, when someone who was orally abused avoids going to the dentist. A victim of abuse might bond strongly to her abuser. This is known as traumatic bonding, or Stockholm Syndrome. And jumbled up memory, when a person's normal recording of memories doesn't work. Can you recall any times you've seen that symptom?
What time? I don't know.
A traumatized person may not seem like her usual self, or may be hypervigilant, on edge, or being startled by everyday things. Everyone is different. You never know what impact trauma will have. Symptoms can change from day to day. So what does all this mean in practice, in your job? A traumatized person's brain is protecting them, but that normal human response of self-protection can get in the way of evidence gathering. The US military has developed new trauma-informed interviewing techniques that you can use to work around this. Research shows that if someone seems vacant, they could be distracted by their traumatic memories. Try to ground them by asking a simple, non-patronizing question such as, "Are you thirsty? Do you want a glass of water?" This can help bring them back to the here and now. Don't expect a logical, linear story. Ask, "What can you recall just now?" Find out what the victim physically felt or saw. Working this way, from the instinctive sensory parts towards the logical parts of the brain, you'll get more results. In conclusion, 4 things for you to take away. Trauma response is the brain in survival mode. Repeated abuse can make trauma symptoms worse. In response to trauma, people will behave in unexpected ways. Remember, trauma is a normal human response to abnormal events.
We know that you've gone through a really painful experience, but we need to take a statement to understand what happened on Saturday night.
Are you able to tell us anything that you remember about this flat? Anything at all?
A dog. Barking.
Are you able to remember any physical sensations or feelings that you had?
Cigarette smoke. Can smell it now.
What was going through your mind?
I couldn't understand it. I just couldn't move, or even scream.
To freeze is a perfectly normal response. So you start with the memories, you don't start at the beginning. You have to engage with feelings to get to the facts.
Makes sense. Check you, Professor, getting all sciencey on us.
Well, if it gets us usable evidence.
There's life in the old dog yet.
Oi.
Okay, so I thought that video really summed things up very well, and in fact gave us some tools as to how to elicit some information from our patient that has just gone through a traumatic event. And I had the pleasure of teaming up with Kennewick Police Department a couple of years ago to aid in the trauma-informed care among the officers. So we're all kind of learning as first responders there how we can better take care of our patients and not put any blame on the victim. So, since trauma can have a serious effects on the health, behaviors, relationship, work, school, and other aspects of life, it is important for behavioral health, healthcare, and other providers to gain the knowledge and skills needed to promote healing, recovery, and wellness. So this is just a little statement about trauma-informed care there. So we're going from what is wrong with you to what happened to you, and we're going to accept symptoms and difficult behaviors as strategies developed to cope with potential childhood trauma. So that trauma that's going to happen over and over and over again. And they're really finding out a lot about our ACEs there, our adverse childhood events, and how they have informed all areas of our behavior and cognitive and decision making as adults even there. So here's a little overview then about post-traumatic stress disorder. So we are going from that acute moment to our long-term effects here. And it started off kind of as soldiers had come back from army, from wars, with originally Leopold, who coined the phrase soldier nostalgia. And then in World War II, they called the soldiers with post-traumatic stress disorder as shell shock or battle fatigue. And it's currently known to affect obviously more than soldiers. So they went from battle fatigue or shell shock to this post-traumatic stress disorder. Here's a little information about the prevalence of PTSD. So not everyone that has gone through a traumatic event will develop post-traumatic stress disorder. In fact, up to 70% of adults will experience at least one trauma, but only out of those, 1 in 13 will develop post-traumatic stress disorder. And then we have 20% of people who experience a trauma will develop that post-traumatic stress disorder. So I guess 1 in 13 is all individuals, I should say. Prevalence of PTSD in the United States is equal to the total population of Texas, so nice and big. We have lots of stories to share. So most people exposed to trauma do not have the PTSD. We do know that there are some genetic factors that play a role in our susceptibility to having PTSD. For example, there's changes in gene expression. So interesting kind of facts. They have found that among Holocaust survivors, their children, the children of Holocaust survivors, have an increased rate of PTSD, even though they never experienced the Holocaust themselves. And they did a study among rats and cherry blossoms, and they would give these rats a nice smell of cherry blossom and then attach it to a external stimuli that was noxious, such as an electrical shock. And they found, that over time these rats would smell the cherry blossom and then they would kind of run into more of that limbic system brain, do the, fight, flight, or freeze, and have a large limbic response there. And then when these rats had pups, they would give them a smell of the cherry blossom alone without this noxious stimuli, and these pups had the same response as their parents ended up having. So interesting kind of gene expression with that post-traumatic stress disorder. And I'm guessing that we're just at the cusp of finding out a lot more about PTSD. So DSM-5 criteria, the person has an exposure to a traumatic event that involves actual or threatened death, serious injury, or sexual violence in one or more of the following ways: where they have directly experienced the trauma themselves, where they have directly witnessed the events that occurred to others, where they are learning that a traumatic event occurred to a close family member, and where they're experiencing extreme or repeated exposure of trauma to others, such as first responders, aka us nurses, right? So the patient must experience a re-experiencing the trauma, where they'll have intrusive memories, flashbacks, nightmares, and a reaction to cues, just like that video where that briefcase was that trigger there. They might or will have avoidance and numbing, where they have avoiding thoughts, reminders, diminished interest in activities, and restricted affect. They're going to have negative cognitions and mood associated with the trauma, and they will be hyper-aroused, hyper-vigilant, irritable, experience some insomnia, they startle easily, they have poor concentration. So within a 1 month of time of the traumatic event, they will diagnose this as something called acute distress or stress disorder, and if the symptoms persist for greater than 1 month, we can now call it post-traumatic stress disorder. So once again, here's the symptoms. Medical consequences that occur due to this. the patient might experience some cardiovascular disease, obesity, diabetes, hypertension, some substance abuse disorders, chronic pain syndromes, alcohol use or alcohol abuse, depression, anxiety, and poor self-care. So there's a really terrible sequela of events that can occur due to our post-traumatic stress disorder. And then our risk factors include the severity and nature of the trauma. So the higher the severity, the more ugly the nature, the more likely we are to have the PTSD in many cases. History of those adverse childhood events, or you guys will often hear those called ACEs. History of ineffective coping, low social support, low heart rate variability, and I might add here personality disorders. Low cortisol can be a risk factor for these guys, and in fact they've actually done some studies, and some people are implementing this, that within 24 hours of a traumatic event they will give this high dose of cortisol, and you might think that that's counterintuitive because you don't want to be triggering this fight or flight response kind of anymore, but they did find that this booster of cortisol can be effective as far as the patient having PTSD symptoms. So kind of interesting stuff. The hippocampus, that's our contextualizer, right? It's smaller in PTSD. So twin studies have found out that that there's a genetic expression to that, or genetic variability, physiological variability there. So having a smaller hippocampus to begin with might put you at risk for PTSD. And then if you have a learning disability or an intellectual disability, you will be at a higher risk factor, and then less cognitive flexibility. So we're thinking things in the black or white fashion might put us more at risk for having PTSD. Therapies of these are cognitive behavioral therapy. They might do exposure therapy, where really they're just making this is a thing that happened, and we're not going to give a good or a bad thought to it. We're just going to keep exposing you to the thought until it just becomes a neutral thought. So that's the idea behind exposure therapy. Eye movement reorganization is kind of similar to that neuro pathway where we're using these anti-seizure medications. The eye movement reorganization will help that. So they induce rapid eye movements in a patient, and that might help a lot. Another thing that a person could do is just drive or be a passenger in a car and look at the scenery. That'll induce that rapid eye movement there. And then our beta blockers, for the same exact reason as for our anxiety-filled patients, and SSRIs, and oddly enough, once again, inducing our cortisol level by adding a decadron, a steroid, dexamethasone. So let's talk a little bit, and we don't really have enough, so much time in this lecture, but I do want you guys to think about your own kind of secondary trauma. This refers to the presence of PTSD symptoms caused by at least one indirect exposure to traumatic material. Several other terms capture elements of this definition, but are not at all interchangeable with it. A nurse, such as yourself or a future nurse, might experience all of these things, compassion fatigue. That's a less stigmatizing way to describe secondary trauma stress, and has been used interchangeably with the term. Then we have our vicarious trauma. That refers to changes in the inner experience of the therapist or the nurse resulting from empathic engagement with a traumatized client. So you're giving direct care to that patient. And we do a lot of things that we don't realize that we do. They call it like mirroring. We actually kind of obtain the same kind of responses as the patient might. And then burnout, let's talk about that. It's an emotional exhaustion, depersonalization, and a reduced feeling of personal accomplishment. While it is also work-related, burnout develops as a result of general occupational stress. The terms is not used to describe the effects of indirect trauma exposure specifically. So we can achieve burnout without being among the people that are exposed to the secondary trauma. But just know that these things exist, and start thinking how you yourself are going to protect yourself against these kind of elements as you are exposed to them at work. It is not a bad thing to have a therapist that yourself that is knowledgeable on secondary trauma responses, and some cues that you can use during your day to figure out how you're going to help yourself with this. So one thing that they have used is our peers. So we can use our peers to reduce these symptoms. They're really kind of leaning on each other and having like a brothers in arms type culture in your area of your place of employment might be very helpful for you. I suggest also that you find a mentor, and they don't always come to you, you can come to them. So all the mentors I have chosen over the years, I have told them, you are now my mentor. And having that person that has experienced the things that you have, and being able to be, to have that soundboard. If you guys are venters, please consider having a mentor that's going to be able to listen and really kind of know what you're going through. So we need to recognize within ourselves these symptoms of compassion fatigue, and once again, figure out how you personally are going to be able to help yourself, help your patients, right? So at the end of the day, we are all humans. Apparently we're not superheroes, even though we're told we are, right? Anyways, I hope you learned something, and I'll see you on the next one.